Hello friends, today we are discussing about permanent pacemaker. So in some patient, this is the conduction system of the heart from sinus node to the AV node, from AV node to the uh, bun, uh, right this right bundle branch and the left bundle branch, and then anterior fascicles and the posterior fascicles. So in some patient, there is a problem with this intrinsic conduction system, leading to need to insert permanent pacemaker. Now we'll see what are the components of the pacemaker. The permanent pacemaker system is made up of pulse generator, one or more electrodes known as leads, and all of the currently used pulse generator and pacemaker boxes are the variations of lithium iodine cells. These cells work by generating electricity due to the chemical reaction that takes place between the lithium and the iodine. So pulse generator can last on an average between 5 and 10 years. Pulse generator are usually about the size of the matchbox and the weight around 20 to 50 grams. The leads are insulated wire that are implanted into heart transvenously, attached at one end to the pulse generator and the other with myocardium with active or passive fixation. This in turn creates the two-way path through which impulse can be delivered to the myocardium and received via pulse generator. The lead delivers the electrical impulse, exciting the myocardium cells, causing the subsequent contraction. Once the leads are in place, the fibrotic capsule forms over the top of the lead, fixing them firmly in the place. Now, indication for insertion. Any kind of heart block, including sinoatrial block, Mobitz type 2 block, complete heart block, and trifascicular block, symptomatic bradycardia, sick sinus syndrome, ventricular standstill, hypertrophic cardiomyopathy, dilated cardiomyopathy, long QT syndromes, drug refractory paroxysmal atrial fibrillation, bradycardia tachycardia syndrome, pause dependent ventricular tachycardia, ventricular pauses more than 3 seconds in length, and the recurrent symptom. Now, types of the permanent pacemaker are atrial pacing, ventricular pacing, dual chamber sequential AV pacing, biventricular pacing. So this is the diagram which representing the pacemaker code. Now the lead position for the different type of the pacing: atrial pacing, ventricular, dual chamber, sequential AV, that is represent as shown in the diagram C, and diagram D, biventricular pacing. So this is the coding system for various pacemaker. So one is for chamber paced, two is the representative of chamber sense, three, what is the sensing response, and the four, rate modulation. So first letter, as I mentioned earlier, it corresponds to the chamber pace. This can be atrium or ventricle or both. Second letter corresponds to the chamber from which the impulses are sensed. Third letter indicates response to the sense signal. And fourth and fifth columns are additional programmable feature. For example, code such as VVIR implies that ventricle is paced. V ventricle is sensed. The pacemaker will not active if it detects the patient's own intrinsic rhythm, and the rate will change depending on the need of the patient. Rate response adjusts the rate of pacing based on the activity level of the patient. Pacemakers can sense this increase in activity in a variety of ways, including vibration, increase in respiratory rate, and changes in the blood temperature. Single chamber pacemaker. Single chamber pacemaker will pace either in atrium or in ventricle. For example, on demand, atrial pacemaker will pace and sense the atrium. Pacing is inhibited when it detects the patient's intrinsic rhythm. This type of pacemaker requires the patient to have intact conduction system and functioning AV node. Single chamber pacemaker that pace the ventricle work by pacing and sensing the ventricle. Primary benefit are for the patient who require intermittent pacing or those with complete heart block. This type of pacemaker does not affect the atrial activity, so the atrial kick contribution to the cardiac output may be lost. So in this diagram, the line below the ECG is the pressure waveform, which is dampened when the ventricles are paced, showing the effect of loss of atrial kick on the patient's pressure. Another problem with this lack of synchronization is the mitral and tricuspid insufficiency that could develop. So this type of pacemaker is normally prescribed for patients who lead more sedentary lifestyle. Now, dual chamber pacing has been shown to produce small but potentially significant benefit for patients with sick sinus syndrome and AV block when compared with single chamber ventricular pacemaker. Dual chamber pacemaker are often given to more active and younger patients. Systemic review found a significant statistical improvement in patients' exercise capacity when given dual chamber pacemaker as opposed to the single chamber pacemaker. So the dual chamber pacemaker respond to each atrial stimulation and activate the ventricle when this does not occur naturally, ensuring AV synchrony. Biventricular pacing, also known as cardiac resynchronization therapy, and is used for treatment of heart failure when patient fulfills the required criteria. So the undergone describes the heart failure as a relative common condition with poor prognosis, characterized by the reduced cardiac output resulting in arterial underfilling, causing the body to retain fluid and thus increasing fluid volume. This can lead to systemic venous congestion and pulmonary edema. So CRT uses the three lead placed in the right atrium, right ventricle, and third pass through coronary sinus to pace the left ventricle from behind. So leads are not passed directly into left ventricle. They are at risk of thromboembolism and impairment to the aortic valve, possess an unacceptable risk to the patient. CRT attempts to improve efficiency of the pump action of the heart by resynchronizing the pumping action of the heart's chamber. This work by improving ventricular contraction by stimulating right and left ventricle, improving cardiac output, diastolic left ventricular filling, and ejection fraction. So the patient criteria for cardiac resynchronization therapy, New York Heart Association symptom class 3 to 4, patient in sinus rhythm with QRS on ECG more than 150 or QRS on ECG of 120 to 149 with mechanical dysynchrony confirmed by echocardiography. Or in case of left ventricular ejection fraction less than 35, currently receiving optimal pharmacological therapy. Fluoroscopic, now the second diagram, which is a figure 6, representative of the fluoroscopic image of biventricular lead position. Now the recognizing pacemaker on the ECG. The main indicator of pacemaker on the ECG is the presence of pacing spike, otherwise known as pacing artifact. These spikes occur as pacemakers send electrical impulse to the heart muscle. The location of pacing spikes shows that which chamber are being paced. Ventricular pacing causes the broad QRS complex on the ECG as electrical impulse does not travel down the normal fast conduction path. Now, this diagram is the representative of the pacing spikes on the rhythm stream. So, diagram A is representative of single chamber ventricular pacing. Pacing spike located below before QRS complex. The underlying rhythm is complete heart. Diagram B is representative of dual chamber pacemaker. Pacing spike located both before P wave and before QRS complex. Bipolar and unipolar leads. All electrical circuits have two poles. The positive pole called as anode and the negative pole called as cathode. The unipolar leads have the pole on lead itself, where bipolar lead have two poles on the lead. The large circuit made by unipolar lead causes the large pacing spike on surface ECG, and small bipolar circuit causes the smaller spacing spike on the ECG. Now about the preparation of the patient. The procedure should be fully explained to the patient and any questions and concerns should be addressed. Patient should be prepared for the procedures by taking blood, including full blood count, urea and electrolytes, and international normalized ratio if appropriate. The patient should have 12 lead ECG, validated consent form, intravenous access for delivery of the prophylactic antibiotic, and any sedation that may be required. Prophylactic antibiotic, that is flucloxacin and vancomycin, aid in the reduction and prevention of PPM infection. Aspirin and clopidogrel are also stopped if possible for around 3 to 4 days before the implantation procedure. Warfarin can be stopped 4 to 5 days prior to the procedure. INR should be less than 1.5 to prevent hematoma forming around the pacemaker box. And warfarin is normally restarted the same night as the procedure. The decision to stop warfarin and aspirin may vary depending on the individual patient risk assessment. PPM is normally positioned in the non-dominant side. For example, if the patient is right-handed, then the PPM is positioned into the left upper chest and the vice versa. When cardiac monitoring is used before implantation, the sticky residue left behind the electrode can be removed with the acetone. Alternatively, the electrodes can be positioned away from the implant area to avoid the need to do this. Implantation procedure. The PPM is normally inserted in theater and cardiac catheterization lab, with the patient being fully conscious and optimal sterility maintained throughout the procedure. Implantation procedure normally lasts between 60 to 90 minutes depending upon the type of pacemaker inserted and individual patient factor. During the procedure, the patient's ECG, blood pressure, oxygen saturation are measured normally. Patient's non-dominant side is used for implantation. Transvenous access is normally achieved via subclavian cephalic vein located just below the column. The leads are positioned using fluoroscopy to guide them into correct position. The permanent pacemaker pocket is made for the pulse generator, usually located subcutaneously in the form of pectoral muscle, in the front of pectoral muscle. Sometimes for the young and thin females, the pocket can be located in the retromammary and the axillary position. Following the procedure, patient should be monitored to establish underlying rhythm and to highlight any pacing irregularities. In addition, the patient should also receive regular observation and regular checks of the wound to monitor for signs of infection and hematoma. The implant wound can be closed in a variety of ways, including staples, glue, dissolvable, and non-dissolvable suture. Local trust policy should always be followed. Any non-dissolvable closure methods such as staple and non-dissolvable suture are usually removed at local practice surgery around 7 to 10 days after the procedure. Patients are usually followed up in pacing clinic once and twice in a year post. The frequency of follow-up for each patient will depend on the factors such as his or her overall clinical condition and type of pacemaker implant. Post-insertion complication associated with PPM, such as pneumothorax and hemothorax. There is a small risk of pneumothorax when supplement vein is used for lead access. Breathlessness and the increased pain on inspiration may occur following pneumothorax and hemothorax. Other symptoms can include an increase in respiratory rate and cyanosis. This can lead to the need to insert the chest. Chest X-ray in addition to the fluoroscopic image, as it is hard to identify pneumothorax and hemothorax when the patient is lying down An upright chest X-ray should be used. Then the next complication is infection. Infection of the bone may occur. Many clinicians attempt to further reduce the risk of infection by adding antibiotic to pacemaker pocket, such as gentamicin, ETH. As a result of low-grade infection and other mechanical means, the pacemaker can start to protrude through the skin. Monitoring the patient's vital signs, including temperature, accompanied by regular checks of the wound site for swelling, pain, redness, inflammation, or weeping, can alert the nurse to the signs of the infection. Now, re-enter tachycardia. Pacemaker mediated tachycardia is a problem associated with dual chamber pacemaker system. A retrograde conduction trigger a loop of events resulting in sustained tachycardia. This form of tachycardia is not caused by a pacemaker but owing to retrograde conduction. The pacemaker acts as a path for re-entry of the electrical impulse, generating never-ending loop of tachycardia. This is usually triggered by the premature ventricular contraction. So the premature PMT can be seen on the ECG by closely grouped pace complexes and can usually be prevented by prolonging atrial refractory period. Many pacemaker can detect the PMT and automatically prolong the atrial refractory period for one cycle to interrupt the tachycardia. PMT may cause hemodynamic instability. Appropriately trained staff can use magnet to stop atrial sensing, or alternatively, the pacemaker can be reprogrammed. Pacing the diaphragm. In some cases, pacemaker may stimulate patient's diaphragm due to proximity of the electrical signal to the phrenic nerve, causing hiccups. Next complication is cardiac tamponade. Direct trauma inflicted during the implant procedure can cause pericardial sac to fill with the fluid, causing elevated pressure, which in turn prevents the ventricle filling properly and can reduce the stroke. Next complication is pocket hematoma. Bleeding into pacemaker pocket can occur. To reduce the risk of the patient's INR should be less than 1.5 before implantation, unless there are clinical reasons that require a higher INR. Now, the next complication is a lead displacement. Before fibrotic capsule forms to better hold the lead in place, the lead can become displaced, causing pacemaker not to function as intended. Most patients receive chest X-ray and pacing check to confirm lead position before discharge. Now, the pacing problem. There are various problems associated with pacemaker malfunction. To this end, the patient is usually placed on the cardiac monitor overnight, receives regular observation to ensure the pacemaker is functioning as intended, and identify any potential hemodynamic component. When presented with any of these problems, it is important to monitor patient's vital signs. 20 ECG should be obtained. Now, these are the pacemaker malfunctions, like failure to capture. The first diagram is representative of the failure to capture. That means pacemaker will produce impulse but fails to pace the myocardium. Now, the effect on the patient, it can expose the patient to condition the pacemaker was inserted to treat. Now, how to identify? There will be the pacing spike on ECG without appropriate atrial and ventricular response. Then the next common pacemaker malfunction is failure to pace. That means no impulse is generated by the pacemaker, and it can lead to reduced cardiac output and subsequent drop in the blood pressure. There will be the no pacing spike and subsequent PQRS wave when expected. Then the next problem is undersensing. The pacemaker fails to detect the intrinsic cardiac activity and pace any. The patient may be aware of palpitation and misbeat. If pacing spikes fall on the T wave, this can be dangerous and can cause ventricular tachycardia and fibrillation. Pacing spikes seen on the ECG at various points in the cardiac cycle, not before P waves and QRS waves as would be expected. Placing magnet over the pulse generator reverts the pacemaker to asynchronous mode and can be used by appropriately trained person to determine the battery life of the impulse generator. To allow the use of emergency pacing if pacemaker is malfunctioning and identify which chamber are being paced and assess the capture. Magnetic application can also be used to pace the patient despite presence of electromagnetic interference. Now, the clinical considerations. Some clinical equipment and tests can affect the functioning of the permanent pacemaker. Health professional caring for PPM patient should be aware of these possible effects and take steps to reduce the risk of PPM patient. Now, advice to the patient. Patient living with the PPM should receive health education pertaining to the pacemaker. Current UK driving law states that no driving is allowed for 1 week, and patient with the Group 2 license should not drive for 6 weeks. Patient should also be advised to keep wound dry for 5 to 7 days until wound is both dry and healed. Patient should also be advised to see the relevant health professional if there are any signs of fever, infection, pain, swelling. Vigorous activity and contact sport should be avoided following insertion of the PP. If non-dissolvable stitches and staples are used to close the wound, patients should be advised to have them removed in 7 to 10 days. Patients should carry their pacemaker card detailing the type of the pacemaker. This card should be presented to doctors or dentists prior to any procedure. Source of the electromagnetic interference can cause pacemaker to revert to asynchronous pacing and prompt unnecessarily pacing and even mimic cardiac activity. Patient exposed to any source of electromagnetic interference should that could affect the functioning of the PPM should not linger near its resources and expose themselves without due reason. Pacemaker patients should always be advised to avoid areas displaying no pacemaker signal. So, potential sources of electromagnetic interference that need to be avoided are airport weapon detectors, CB radio transmitter system, from dental drill, shop anti-theft system, mains driven electrical motor, magnet, vibrations, high powered radar station, and mobile phones. Patient normally advised to use opposite side of the pulse generator. Thank you.